I think we better start, Julie, if that's...
Yeah, that's fine. Adele's here.
Adele's, okay, so we can go on to the presentation and then... Okay, in which case, welcome everyone. Welcome to, I think we have two observers, Zoe, who's interested in becoming a NED, I think, and one of our governors, Stephen, but she's not on the call yet. And just formally to remind them both that they don't take part in the meeting, but I'll have a little bit at the end of the meeting if you wish to make a comment or something. And also just to remind the public who watch these meetings that they're all recorded and you can see them online on our website. Okay, we've got no public questions for this meeting. Any apologies?
We've got Rajiv Gaffer and we've got Mark Day.
Oh yeah. Declarations of any business on this meeting or on the agenda, on the register? No. Minutes of the last meeting 5.1. Any corrections, please? Action log and matters arising, I think, are all in hand.
Sorry, Martin, just on the action log, I've just noticed I did have a question on number of leavers within the first year last year, which I've missed, so I'll pick that one up.
Oh, thank you. Thanks for that. Okay, if we can make sure that's recorded. Thanks so much, Paul. In which case, we'll go on to the quality section. Item 6, the patient stories on Op Courage. And some of us were very pleased to be present when the Minister for Defence People and Veterans, Mr. Doherty, came to see our team, meet the team and some of the veterans, which is great. And I thought it was a very impressive visit, but it's a chance for now for us to all hear about it. So Alex, over to you.
Thanks, Martin. So Op Courage, or Operation Courage, is the banner for our regional partnership for delivering veteran services and for those acting personnel, live military personnel moving and transitioning out of the service, providing really critical mental health and wellbeing support to veterans who have often found it difficult to access the service they need at the right time and in the right place. So really delighted to introduce Adele Stevens to take us through the service, and it is timely because NHS England has seen the benefit of the services that we're providing with our partners across voluntary and charity sectors, with peer support workers and with dedicated clinical teams, and they are now procuring formal services going forward on a regional basis. So very exciting from a partnership perspective. And I'm sure Adele will introduce some of that. We were hoping to have Major Dan Brooks join us, who is our military lead for the veteran services. He's just been deployed out to the Falklands as a reservist. We've supported that deployment and very proud to do that. Dan was intending to join, but may have had some connection problems. He may join during the presentation. Adele, welcome to you. Thank you very much.
Thank you. Yes, thank you very much for inviting us to speak on our services. And like you said, Alex, it's it's I think it's a really good time to come and present on the service we're doing and all the good work that's happened within the trust and directly within our service over the years. So I'm just going to share my slides. I'm assuming everyone can now see the slides. Great. So yes, Op Courage, Alex did the introduction, and that's exactly what we are. We're a veteran, NHS provided, veteran mental health and wellbeing service, and it's Berkshire Healthcare that supports that provision across quite a large region, as we'll see a bit later in the presentation. So I think it's really been fantastic, actually, the amount of support that we've had in the trust, and to see the trust's commitment to the armed forces community. So not just within the direct Op Courage provision, but just the wider work that has happened in the trust to get our trust in a position to advocate and support the armed forces community, so veterans and their families as well, and those transitioning out of the military. And I think within the past 2 years, there's been a real momentum of work within the trust, and it was initially spearheaded by people within our service who are obviously committed and enthusiastic to ensuring that we're meeting the needs of veterans. But it's been really taken up with enthusiasm and a lot of time and effort put in from wider kind of key people in the trust, actually, and that's allowed us to achieve a lot. And I think it's lovely, isn't it, when hard work kind of manifests itself in concrete recognition and awards, and this is some of the stuff that we have achieved, not as a service but as a trust, working together with the service over the past 2 years. And actually this is kind of hot off the press, so I'm really proud to be able to say today that we've been awarded the Gold Award as part of the Armed Forces Employer Recognition Scheme, which is a real achievement and just demonstrates our commitment to advocating for the armed forces community as a trust. So that is really fantastic. We're also veteran aware. We also have, which I think is probably the first one in the country, possibly, as far as I know, but we have a staff network called the Courage Network, and that is for members of Berkshire Healthcare, so people who are veterans themselves and now work in the trust or are allied to the armed forces in some way. And that is just a fantastic support network. It's a source of being able to share expertise across services within the trust. So that's a really, really fantastic thing that's been achieved as well. I'm not going to go into the wider bit anymore, because if Major Dan Brooks does join us, which is the plan as far as I know, then he can explain and touch on this stuff much more. But it is really just to highlight the fantastic work that has been done and how that actually supports our direct clinical work as a service. It's really, really important. So these services go back a long way, really, and Op Courage is just the most recent manifestation. So we've been providing veteran services in Berkshire Healthcare since 2012, and the first incarnation of these specialist veteran services, really, from NHS providers. So we've really been there from the start, and I think it's really, I wanted to note that there are staff who were in that original service back in 2012. In fact, the majority of them are still in our services today, and that's really fantastic. It just goes to show the support we've had within the trust in terms of retendering, service delivery, but also vitally the expertise and specialism that has been built up within these teams over that decade of specialist veteran provision. So what we've really seen, I think, is an evolution of these specialist veteran services, and they have hugely expanded from what was probably kind of about 3 people back in 2012 to now, a huge, a large staff team, and covering a large region. As you can see there, we go across not just Berkshire, but what we call the South Central patch, so Oxfordshire, Hampshire and Isle of Wight, and Bucks as well. So there was this sequential transitioning of services. It started with the Transition Intervention and Liaison Service, which was a key part of that was having in-reach into the MOD. So previously there'd been a problematic barrier between a cut-off, very hard cut-off when you leave the services, and the MOD ceases to be responsible for your well-being and mental health support, and it's handed over to the NHS. In terms of responsibility, and that service has really done a lot to bridge that gap, and we can now work with people for 6 months prior to their discharge, which is just vital to ensure a smooth transition process for people. Then the Complex Treatment Service was commissioned. That's a specialist psychological treatment service. So we provide military adapted, military specific treatments that we wouldn't expect more mainstream NHS services to provide. Things like treatments for moral injury, combat PTSD, where you maybe see a lot of survivor guilt, shame, and you're dealing with that really complex issues like the clash between peacetime code and wartime code and things like that. It leaves people in a lot of difficulties when they then have to readjust into civilian life. Then more recently, there was the commissioning of a pilot high intensity service, and they piloted different models around the country. So we have been responsible for providing that across part of the South Central region, and that's really a bit of the kind of wraparound care and support, and really about re-stabilizing veterans so they can continue to engage in their treatment journey. I think often what you see with veterans and people who are struggling with complex problems is disengagement and disrupted treatment, and that service goes away to stop that happening for our veterans. Then in 2021, there was a launch of Op Courage, which was effectively a rebranding of TILS, CTS and high intensity for Op Courage. And we were actually quite grateful for that, because those are all quite lengthy titles. So it just made it a bit easier for us to answer the phone and say who we are, but also just for the veterans and the referrers to understand what was happening and not have to get caught up in all the complexities of which bit are you getting and which bit do you need. It operates as a seamless service. People just come in through the front door to TILS, the big green cog, and if they need, they will go smoothly into the psychological treatment phase within CTS, and as and when needed, wherever that may be in their treatment journey, the HIS service can come in and offer their support as well. So yeah, we don't ask referrers or veterans themselves to be concerned with what they need. Our job really is, as soon as they come to us asking for help, that they get the help they need quickly, that they feel that they are engaged, they have staff who are committed to supporting them, understand the interaction between their military culture, their military career, the transition into civilian life, and their mental health. And I think understanding those three bits is kind of one of the key things that our service offers and does that you wouldn't really expect a mainstream NHS or charity service to really offer. So it's really about just getting people the help they need once they're in, and helping them to engage in what they need to do to get better and rebuild their lives. So veterans' needs. I guess the fact that the NHSE have commissioned a specialist service for veterans and have done so now for years suggests that there is something different about the veteran population which warrants a specialist service, and that's very much what we see on the ground as well. So there are things specific to veterans, and I think there is a real kind of legacy really of kind of a military mindset, and that can interact in very complicated and unhelpful ways with the challenges people face with the transition out of the military, and also mental health problems. So when we look at transition, for example, that's something to understand in and of itself. So when people are going through a transition, you've got the social and practical challenges of finding a new job, a new source of income, a new housing, the fact that your family have to readjust to a different role and way of being together. So, but you've also got the psychological transition where you've lost the support, the brotherhood, people often call it, and vitally meaning and purpose, that you feel that often people in the military feel they're part of something that matters. And it's very hard to sometimes re-establish that within civilian life. So that's the kind of thing, for example, that our staff would understand, and the way that we would work with people, that again is just that value added, veteran aware and veteran specific piece. And I guess the other kind of thing to really flag with veterans is the interaction between the military culture and the hangovers from that, and getting help or ways of coping. So a common message sent in the military is, you know, you should be able to cope. You shouldn't feel that shouldn't cause you problems in terms of functioning. You should be able to perform under high pressure and things like that. And then when someone's struggling with their mental health, that causes a lot of problems, because the person feels that they shouldn't have those difficulties, and then they kind of double down on their known ways of coping, which sometimes just don't work the same way in civilian life that they do in the military. And in fact, things that work well in the military can cause problems in civilian life. So ways of communicating that are just standard in the military may not go down so well in a civilian job, for example, and that can lead to employment problems. So the other thing that we often see and we work hard to really address is that if you don't think you should be struggling, you're not going to reach out and ask for help. You're going to try and solve that problem yourself. And that's what we see a lot of our veterans doing, is they've worked really hard to try to solve the difficulties they're experiencing themselves. And unfortunately, that can often lead to greater problems. So as I said, problems, for example, in employment, problems in family relationships, sometimes leading to family breakdown, double downing on those known ways of coping, which can include substance misuse. So, you know, alcohol's a really known thing with the military. So using that to cope with, for example, PTSD is something we see a lot. And you can then see how that could have a lot of unintended consequences, really, that cause more problems in the person's life. So a lot of veterans we see, they kind of reach out for help once they've got to that crisis point. And a lot of the work we do is try to really get to veterans and get the message out there that we provide this help and there is help there for them and they deserve that help. And of course, they need that help as early as we can in their, as early as we can to stop things deteriorating. So what's different about our service? I mean, I've touched on quite a few things there. I think one of the key things that I really wanted to flag today was the role of the peer support workers in our service. So we have a number of staff who have lived experience of the military and also of, you know, suffering with problems as a consequence of their military career, engaging in treatment for that, and then, you know, being in recovery as well. And that has just been a huge, huge benefit to our service. And it's really put us in a position where we can genuinely co-create and co-produce our service. And we can get things right, like we can get the front door right. It's so hard for anyone to ask for help, but especially for veterans, for some of the reasons I've said. So when they do reach out, you've got one chance to get it right. And that, for example, is where our peer support workers are absolutely invaluable. Then we also provide different interventions. So I've mentioned the moral injury, so military moral injury, where you've had to do things in combat that are sometimes hard to, you know, kind of square with yourself once you're back in civilian life and you're back in peacetime society. We use a lot of compassion-focused approaches because they work really well with shame and they work really well with guilt, and that's what we see a lot of. We've got a specifically designed group where we've worked alongside combat stress called Be Your Best Ally, which is a compassion group targeting shame and guilt, and the feedback on that has been absolutely great. We've also developed and piloted another novel group called True Strength, which is a anger group. And again, feedback's been great. And one of the other really fantastic things is there's a whole spirit of collaboration around these services, and the other Op Courage providers have actually come to us, and we've shared our groups with them and co-run groups with providers across the other regions. So that's just been a really fantastic thing to be able to do. And our services have been shaped deliberately for veterans. So we do have things like a dedicated substance misuse practitioner, a dedicated family worker. We really have designed the service to target the highest veteran need, with also in mind the gaps in existing service provision. So where those map onto each other, that's where we can make the biggest difference, and that's where we try to target our the focus of our service. So I would just say on this front, the thing about our service is we are not supposed to replicate the NHS for veterans. You know, we would never be able to do that, and we shouldn't do that, because what we want to do is get the veteran the best help they need. So if they need specialist substance misuse help, it's right that they should access a specialist substance misuse service just as a civilian would, just as they would if they hadn't been in the military. And our job is to support them to be able to do that. A part of us supporting that, as well as just directly getting them through that front door with our peer support workers, is also training staff, providing consultation, ensuring that staff are veteran aware and that they feel confident to do their business as usual and their day job with a veteran, and that when a veteran walks through the door, they're not fazed by that. They don't think that they need to be sent elsewhere and seen by someone else. That if they're the specialist in providing what that veteran needs, our job is to make sure they feel confident that they can do that. So we have a piece, I guess, in working with the wider healthcare provision really across the region as well to support veterans. And effectively our vision would be that we've got enhanced veteran pathways, care pathways across the region that we're helping to support. So yeah, maps onto this bit about veteran informed care, and you know, it's a broad thing really. So it can be anything as specific as I remember our peer support workers, when they first came into our service, said, we're not sure about this word assessment that you're using. And for a clinician, you wouldn't think twice about assessment. You know, it's a standard part of whether you're a mental health nurse, a clinical psychologist, CBT therapist. You know, assessment is that general kind of first part of the clinical journey. And they said, actually, in the military, that has a whole different meaning, and it maps onto a kind of fail or pass. So then if we were assessing people and saying, actually, you need to go to a different service, sometimes veterans were thinking they had failed to get into our service. Plus, as you can imagine, it created a whole load of anxiety about the assessment appointment. So it can be really concrete things like that, to just much bigger bits about how we shape the front door, how we engage with veterans, whether that's a lot of assertive kind of outreach with texts and calls, and getting a named family member they're happy for us to contact if things get more difficult, and right to then the specialist clinical interventions. So it's really about what we deliver and how we deliver it, and making sure that that is credible for veterans and meets their needs to help them engage in the treatment that they need. So that is pretty much me done with the talking, and what we've got is one of the videos that we have made. So there's a number of these videos, and they can all be accessed on our website if people haven't seen them. But I just wanted to show one today that hopefully just captures kind of, I guess, the essence of our service and what we do. Okay, so like I say, that's one of a series of videos we've made. It's targeted at veterans, and like I said earlier, just trying to get that message out there that we're here to help, and get that help early and kind of take that step to reach out. So yeah, I think that's me finished. I'm not really sure if Dan is on the call yet or not.
I can see a number dialed in, but it's currently muted.
Okay.
That might be Dan. Are you there, Dan? Perhaps
No.
move on to any questions.
Right, I think we'll do that. So I think this is a fantastic programme, and said I've had the pleasure of meeting the team and the veterans and the peer support workers in particular. I thought were very interesting when we had the ministerial visit. So colleagues, questions. Can you unshare your screen just so we can see everyone? That's all right, just so we can see. It's easy to see everyone. Sally, I think, has got a hand.
Adele, my name's Sally Glenn. I'm a recently appointed Ned, and I've not come across this type of service before, and it seems to me a very, very comprehensive and successful service. So I'm talking from a position of ignorance, as it were. Is there any research underpinning it? Because it seems such a large service and doing work I would imagine other areas wouldn't be able to do. Is there a research program underpinning this?
That's a very good question. So so there is research that exists, just general research that we would be always drawing on. So as with all NHS services, we're committed to evidence-based treatment and working with people in evidence-based ways. So there's a kind of that broader bit of research which goes on, which we draw on, and then that for also the veteran population. So yeah, we do we rely on that and use that. Then I guess there's been a this whole evolution of the services, worked closely with the NHS commissioners really to feedback what the need is that we're seeing on the ground, and I think that process has been a real evolution of understanding for us clinically and also from the commissioner's point of view. So there is that bit of feedback that we can get from the national picture and the national provision. Also, as a service, what we have got underway at the moment is to develop links and develop our formal research strategy. So we already have links with, for example, Surrey University and other universities where we take on clinical psychology trainees and we support research, but we're just looking to really extend and develop that. So one thing we're hoping to do is set up a military academic specialist interest group. We've already been reaching out to academics in the field, Professor Peter Lee, for example, I think it's Portsmouth University, and who have done really good research. And yeah, we're seeing a positive response. You see a lot of kind of, I think, enthusiasm and real spirit of collaboration. That's what we've been seeing when you're working to support veterans. So yes, but there is a lot of work to be done. There are a lot of grey areas at the same time. Yeah,
it certainly looks right for research to me, and even practitioner research. People that want to do PhDs, practitioners. Well done. Thank you.
Thank you, Sally. Naomi.
Thank you, Adele. Really inspiring presentation. I'm sure that many in the room that you're presenting to today either know directly or somewhat indirectly some have some military connection. So it really is a delight to listen to the service, which is clearly working. My question is rather pedestrian, actually. I'm interested in how you've managed coming out of COVID. It is undoubtedly the sort of service that will have been highly impacted, and how you and the broader vet community have coped with that. Things like, Adele, what was the backlog? How has that looked like? How have you chewed through the backlog? And if there is any thread around the use of sort of hybrid working and technology and how that might have changed, I'd be really interested in hearing about that.
Yeah, no, it's good question. So I think one thing that actually played to our advantage with the whole lockdown and people working from home and not providing services face to face was because we already operate across that big region. We already had made a lot of steps to get our clinicians to be able to work online and work remotely, so that it was an option for veterans, and we're able to offer that as an option. So actually we were literally just doing that and rolling that out as lockdown started. So we kind of very smoothly were able to then switch over to online delivery. Now, obviously, you have some people who don't want to do that and don't want to have their therapy online. So they did then go on to the waiting list. And the services are very much in demand. So we do a lot of thinking with our peer support workers about how to manage those waiting lists and manage people through the periods of waiting. So it may be that they're in our service and we are quick to see them and assess them and get them a care plan, but then there may be a bottleneck, for example, for the psychological therapy that they need. So we do a lot of we've got a group program. Our peer support workers engage with people. We regularly contact people so that they still feel supported during that time. So taking those steps really to try to make sure people don't disengage and that problems don't deteriorate. But yeah, I think the bit I would say about veterans is probably, in a way, what we're seeing with other people, that we all know the people who hit the hardest in the pandemic are the people who were already struggling the most. And there are some veterans with very complex needs. So I think, there's stats that have come out, aren't there, on kind of alcohol misuse. And whilst there wasn't increased use of alcohol services, there were increased deaths due to alcohol during the lockdown, for example. So yeah, that's relevant to the veteran population as it would be to, unfortunately, the wider general population.
Okay. Well, I think time is against us, Del, but could I just thank you and Dan, virtually as it were, and your colleagues for all you do. It's a great service, and I know we're all very proud of it. So onwards and upwards. Good luck. Thank you very much indeed.
Just before you go, a quick comms check. Can you hear me? Can you hear me from the Falklands?
Yeah. Okay. Oh, hello, Dan. Yes, you have the floor.
Hello. Hello, I'll be very, very quick, noting your time check there. Hello all. We're talking about struggling to dial in from 8,000 miles away. So just by way of an introduction, I'm the Armed Forces lead for the Trust, and very soon into my employment with the Trust, I was mobilised and asked to go and command British forces, land forces, down here in the Falkland Islands on one of the rotations. So I'm calling you today from there. My apologies, I can't see you on the screen because of the bandwidth problems that we have from dialing in from down here. So very, very quickly, what are we doing down here, and why am I here, and what am I doing in the day job, and how does that support the presentation that I just mentioned there? So the mission down here, I command a company, a dismounted infantry company of 120 individuals working in a joint forces environment. So that's land, sea, and air. And we are here on with two mission objectives. One is to reassure, and we do that by overt patrolling. We reassure the local population. And the second is we deter, and we deter obvious aggression. And the whole point of us being here is not about colonialism or anything like that. This is, and it's very relevant to the situation in Ukraine today. It's about defending the Falkland Islanders' right to self-determination. That is basically why we're here, and that is our job. What are the conditions like? What are we doing? I've just come in off the field where my troops are dug in on exercise, and it's a ground temperature of about -3 and a wind chill of -20. So it is more than literally freezing here. So the guys are doing really well. And I have a mixed group. I'm leading the first ever group of a mixed reserve and regular 50-50 split. And I have 17 different cap badges that make up my group. So we came together at scale and pace, and we're proving a new model construct for the way that the army can and defence can project itself and continue to deliver its objectives in an ever decreasing manpower environment. but I won't go down that rabbit hole. So that's what we're doing down here. And the point of that is to say thank you to the Trust for allowing me and all of my other reservists, all of the other employers that we have in our area, to come and do this and to do this exercise and to deploy on operations, because this is an absolute manifestation of our overt support to the Armed Forces Covenant. The Armed Forces Covenant is not a bit of paper; it actually means something, and the courage activities that Adele and the team are leading on is groundbreaking. It's pathfinding along the way, but it's really making a difference. It is genuinely saving lives. So we are assisting service either on active operations, or we're supporting those who have been in service. And there are two cohorts that I'd like to just focus on very, very quickly. The two cohorts are, we have staff and we have patients. And the patients that we have who are relevant to this theme either have physical or mental needs in some cases, and we support those with the best service that we can possibly deliver. And the Berkshire team really does have some of the best in the country. And I've managed. I've launched some of the other Up-Courage services, and I can say with absolute integrity that we are leading the country on this. So much so that we presented to Parliament, and as mentioned, we presented to a minister, and we continue to develop, and we've been invited back into Parliament to present some of the brilliant work that we are doing. So we are making a difference, and we are making it work. And all of this just what is it doing? In short, it just reinforces that the staff that we have are delivering an amazing job, supported by a fantastic management and executive for both our staff and our patients, that allow us to deliver the best possible service and be the best possible employer, and deliver the best possible service to those. So in a very quick burst, I hope that reinforces from down here the very practical appreciation that I have for both the staff and the work that we deliver, the management and the executive for the support that they deliver, and in my case for genuinely supporting service people as we deploy on operations on the ground.
Dan, that's absolutely great. Thank you very much for your kind words. And as I know, all the staff of the Trust, we're interested in supporting the people we care for. That's what gives us, the pleasure, if that's the right word. So thank you very much. It won't help me to say, Dan, that the temperature here is approaching 30 degrees. Positive, not negative. But I wish you all the best in your deployment, and look forward to seeing you back home soon. Thank you very much indeed. We must now move on. Well done.
Look forward to seeing you all soon. Thanks, care. Bye-bye.
Thanks, Adele. Well, that was fantastic presentation. Very important piece of work, and it's great to see the Trust leading on this. Can we then move on to freedom to speak up? Mike, are you on the call? You are somewhere?
Yes, I am. I'm just
Mike, we've sort of got the paper. We read the paper. I think what would be helpful if you could bring out one or two things, and I've got a question or two, but one or two things that would help us understand are we on the right track? Because we had a presentation from the National Guardian at the board the other month. There's a lot of detail in your report, but I think it'd be helpful if you could just bring out one or two things that would just give us a sort of feeling, are we on the right track or not?
Certainly, Martin. I think we certainly are on the right track. I think if you look at the annual report from the National Guardian's office on freedom to speak up, there are some key statistics there that go against the experience that I've seen in this organisation. So they have noted that proportion of respondents saying that senior leaders support freedom to speak up fell by 9 percentage points to 71%. My experience is the board and senior management are ever increasingly supportive of freedom to speak up and demonstrate that. The proportion of respondents saying their organisation has a positive culture of speaking up has dropped by 5 percentage points. Again, I don't see that is the experience of this organisation. I am chair of the Southeast region of Guardians. We meet up regularly, and I spend, I suppose, a significant amount of time supporting Guardians in other organisations, not just NHS, but private providers and primary care as well, where the experience of the Guardian isn't as positive as it is in this organisation. So, yes, to answer your question, I can see that we continue to make change. Change is probably not as fast as I would like, but in terms of the listening up and the following up parts of freedom to speak up, been 3 years in post, and that seems to get better year on year. And being involved in safety culture work, dealing with our EDI colleagues or colleagues from other networks. It's slow to draw out any concerns from those groups, but it is slowly happening, not so much through raising cases through freedom to speak up, but some of the survey work I've done with previous EDI lead, talking to some of the services. We've pulled out some key data as to what is actually going on in terms of microaggressions and racial abuse. So a long answer to a short question.
No, that's fine. I mean, the staff survey gives a very positive view of the performance. Tamina.
Yes, thank you. Thank you very much, Mike. And it was really helpful to see the national picture as well as what's happening locally. I had a couple of questions just that came out. There was a comment that one person, I think one of the people who'd raised an issue with you, had said they didn't feel they could raise direct with the SLT, or there were some concerns about doing that. And I suppose my question is there more I can do with my operational leadership team to change that perception? And then a second question, just while I've got the floor, is given we know that through the staff survey there are more staff from a Black, Asian, minority ethnic background who say they have experienced harassment and bullying, I wondered whether we'd considered as an organisation creating some sort of freedom to speak up where people from a specific background might be able to talk to somebody from that background. I just know they've done that in other organisations, and whether that's something we considered here.
So to answer the second part first, yes, so I work very closely with the network chairs of the three networks. I join in with, there's a fortnightly Let's Talk Village Voice type informal meeting. I'm always, or most of the time, I'm there for that. So I engage as much as I can. I can't change who I am, but we are reviewing some of the champions that we have within the organisation, and part of that will be ensuring that the networks and staff side are fully aware and fully engaged with that, so that if there are people that want to be champions, then they will be fully aware of it. And because it will be quite a reasonably formal recruitment process, which is only correct, I think there's not an awful lot more I can do in terms of promoting opportunities to those cohorts. And having said that, I've now forgotten your first part. Is that, sorry, is the more you can do? Yes. I think for all leaders, there's some guidance within the pack from the National Guardian's Office on what senior leaders can do to support. And I think it is demonstrating that anyone that line manages or leads in this organisation is willing to listen to concerns and support that changing culture to make it sort of business as usual. And I think we met last week, and I think the idea is we perhaps meet on a quarterly basis, and I'm sure that will assist.
Okay, thanks for that, Julian.
Yeah, thanks. Good morning, everybody. Martin, my sort of take on it really in terms of your question is that we've got some very positive signs. It's been a very positive meeting so far, but there are a couple of areas that we can still improve upon. So when we come together, that sort of Mike, Debbie, myself and HR, there are a number of teams and areas that repeatedly sort of come up. So it's not necessarily that they're not able to speak up, but they're having to speak up too frequently because issues are not getting resolved. Those issues may be about enmeshed, unhelpful interpersonal dynamics amongst big teams, or it might be about sort of poor leadership in that sort of team and that not getting fixed. So for me, the kind of challenge that we've set ourselves is to really, identify what those areas, prevent them sort of reoccurring by trying to get the right intervention. And obviously that sounds sometimes a bit easier than it is, but I think that's what will make us outstanding for everybody, because we've got good evidence, we've got some really good systems and processes, and we've got good evidence that lots of people satisfied. But we do have sometimes the same teams, areas sort of coming up, if you like, on the radar. And that's the bit of work I think that we've really got to fix. And if we don't, once we've known that's a bit of a challenge for us, really. So I think that's my challenge. That's our challenge, I think, as an organisation, to get better at stopping the recurrent ones.
Yeah. No, sorry. Go ahead, Julian.
Well, because occasionally what happens is Mike sometimes gets a person, it gets fixed, and we never hear from that team or person again. And that's quite normal, really, quite a helpful thing to do. But when you get the same team, the same names mentioned over a period of time, that's the purpose of our meeting, to triangulate, what's going on culturally. I think it's that fix that's the issue, and goes slightly to Mina's question, which is I think that's where the senior leadership can help to really be attuned and attentive to that, and make sure we're taking action on those teams and areas where there's persistent issues.
Yeah, no, thank you for that, Julian. I mean, this is exactly what I think we're all concerned about, is that we're doing very well, but it's those small areas where there's a problem we really need to help resolve. And I suppose coming back to Mike's paper, there's always a slight danger. We look at all the general things we can do, but actually a lot of that is being done very well, as far as I can see, although we mustn't be complacent. But it's how we tackle these hard to reach or hard to resolve issues that we need to do. Sally, is your hand up?
Yes.
Last question on this.
Yeah. Mike, what I should say is that I was the inaugural Speak Up Guardian at another mental health trust, and as a NED, I did it as a NED and stepped down about fairly recently, actually. And first of all, I was going to ask you if you had access to any of these CQC direct complaints from staff in the trust. Sometimes they're anonymous and sometimes people will give their names, but what I found was that often I was trying to sort through an issue with somebody, but at the same time they were dealing with the CQC, or I felt that I closed it down, and in fact they then subsequently complained to the CQC. And I wondered if you'd actually looked at that data at all, and whether it sort of told you anything.
So when I meet on a monthly basis, sorry, Sally, welcome to the organisation. When I meet on a monthly basis with Debbie, HR and Julian, we triage and triangulate the data. So Debbie would be aware of any reports to the CQC, and if it correlates with somebody that comes to me as well, then as a group we would be aware of that. Did you want to add to that, Debbie?
No, I was going to say the same thing. We get very, very few staff going direct to the CQC, and absolutely, I know about every single one, and Mike and I have conversations both at the monthly meeting, and also if it was something I was concerned about, I would be catching up with him outside of that to flag it up to him. I can count on one hand though the number of staff we've had go direct to the CQC in the last sort of year.
Oh, right. Thank you. That's interesting. My experience was it was more common. So thank you.
No, we do get patients go direct more so than staff.
Okay, well, Mike, thank you for that, Debbie. Mike, I think you've got our full support, and indeed your recommendations, I know everyone will support. And I think we mustn't be complacent. We're in a good place, but we know we've got more work to do, and I think everyone's already committed to that. So thank you very much. I think we must move on, however. Debbie, over to you and your complaints report.
Yeah, thanks, Martin. This is going to be really quick. This is a statutory requirement that this comes to the board, but it is a collation of everything that the board sees every single quarter. So it's just a summary of annual complaints. I don't propose to say anything more about it, to be honest with you, because we talk about the quarterly report every quarter, but I'm happy to take any questions.
I've just got one minor one, which is about the definition of a complaint, because somewhere in the paper it talked about multiple complaints from an individual, and in the tables, where it has complaints by different service, etc., it's not clear to me whether that's the number of individuals who've complained or the number of complaints. So when you have a multiple complainer, does that count up a big number, or does it count as one? Go ahead.
It counts as multiple, so every complaint is an individual in its own right. So if a patient complained 5 times, that would register as 5 complaints.
Okay. Any other questions for Debbie? Okay, and Debbie, thanks so much. We've read the papers. A medical appraisal and revalidation, Minu, another positive report, I think.
Thank you, Martin. Yes, this is a standard format which is prescribed by the division at NHS England to present the report, and after approval from the board and sign off from the chair, I submitted to the higher level responsible officer, who was my responsible officer, so to say, in NHS England South, to assure them that our revalidation and it's mainly our medical appraisal processes are going according to the provisions set out. So this is a summary of our numbers. I'd say very positive. We've had no non-engaging doctors, and non-engaging doctors are the significant concern for many trusts, where doctors just are not interested in appraisal and say keep delaying it for all sorts of reasons, or just don't engage. We don't have any of those ever, really, and the only delays we have are very reasonable causes, COVID, work pressures, family reasons. There's only one who had a lot of clashes of annual leave with themselves and the appraiser, and I just did not approve that one. I thought that was taking it a little bit too much, although that individual did complete their appraisal within a month of the delay. So, so this is the full summary. We collect feedback, complaints, we do quality assurance, everything is there. Happy to take any questions from.
Okay, thank you very much, Minu. Naomi.
Yeah, thanks, Minu. And you kind of hinted at this, which is the broader context. I'm just interested in your insights, if you have any, around what this looks like across the UK or across England, NHS England. There's an increasing amount of media attention on GPs and the primary care domain, dissatisfaction amongst GPs. And are we seeing a sort of trend emergent here around engagement across the doctor community?
The issue here is now, prior to the COVID pandemic, we used to have what we used to call comparator reports for every region. So we could compare ourselves with other trusts in the region, and we always came out very, very well, even in the comparator reports. But since the COVID pandemic, all that sort of national information has ceased. So I don't have visibility on that, which is a pity. And hence we collect our own data and we present it to the region. If I have to be honest, I think the system, so as to say that NHS England, the GMC and others have been quite responsive to doctors' pressures, workload, etc., and have tried to simplify or give guidance which simplifies the appraisal process significantly, so that doctors do not spend hours and hours and hours just collecting loads of information simply to prove that they were doing a good job at work, which the vast majority do. So in that sense, it has been responsive. I think there's some further work being done by the GMC to bring this, as an approved process, what they call the Appraisal 2020 approach, which is, have a good discussion, have a supportive discussion about how doctors cope with workload, etc. In terms of numbers, I think what we see in the press about dissatisfaction and pressures is a slightly different matter from appraisal and engagement, because usually doctors will engage with appraisal, simply to just be able to discuss this well with a colleague. So the two are slightly different processes, although one can influence the other, certainly, as you say, Naomi.
Okay. If nothing else, we're just asked to note that it's a very positive and reassuring or assuring report. The process is working well. Thank you very much, Minnie, for that. Okay. Next one is the Quality Assurance Committee. Sally, we've got the papers, so there's no need to go through everything bit by bit. But anything you want to raise, I have to say thank you very much. It looked a very thorough meeting, very well chaired meeting, Sally, if I may say so. So if you've got anything you particularly want to raise, and then perhaps we can just touch on the learning from deaths and the Guardians of Safe Working, which we just a chance for people to ask any questions.
Martin, I was simply going to say, I'm sure colleagues have read the paper, the minutes of the unconfirmed minutes of the 7th of June, and I would be very happy to take any questions.
Okay, thank you. Any questions for Sally? No, it's very thorough meeting. And then just on the learning from deaths and the Guardians of Safe Working, I mean, the reports are there. Go on.
Yeah, well, the reports are there. I think the committee, in terms of learning from deaths, was assured that there's a robust governance process around that, and the numbers around second stage reviews by the mortality review group are outlined there. And I understand that there was one lapse of care identified, but that was back in February 2022, and there've been no other lapses of care. But again, I'll pause there, and if anybody wants to ask any questions around that particular paper before I go on to the Guardian of Safe Working.
Any questions? No, I'd move on to the Guardian of Safe Working.
And again, robust assurance processes around that. We've got the Guardian of Safe Working appointed. I understand there was one episode of a junior doctor having to leave slightly later because he'd stayed on to do an assessment of a mission that came in at 4:30, but there's no breaches of the working hours and no other patient safety issues. So a very a very good situation.
Thank you very much. In which case, I think we'll move on. Thank you very much indeed. Executive report, as usual, we'll take it as read, but any questions in the paper that Julian's produced? No? Okay. Performance, Paul, over to you, item 8.
Thanks, Martin. So just to be clear, the month 2 finance report is against our original financial plan that we submitted in the beginning of the year, and not the revised financial plan that went in at the end of June. So this one's reporting against our original 2.7 million deficit plan. Just to head off as well, Naomi, before you ask about cash flow, we've made those amendments to the month 3 report. We just haven't had a chance to incorporate them into the month 2 report. So just to give an update in terms of, obviously the plan went in June, revised the plan to a 0.9 million deficit. Couple of things just hanging from planning to update on. We mentioned that we were in conversations with NHSE about coming out of the elective recovery scheme. They've come back and confirmed that they're not changing any of the rules for us this year, so we are still counting our activity towards the elective recovery, which means we've got the opportunity to earn the 2 million we've got into plan and potentially higher than that if we exceed the current levels of activity. Obviously, we've identified a small number of services where there's probably some potential, including physio, where activity dropped off quite heavily over the last couple of years, and lifting of the IPC rules is helping. Obviously, we're just minded that COVID is still of a much higher prevalence than was assumed in the planning guidance, and that's going to have an impact on levels of activity, certainly over Q1. Other thing just to note is we've still not had confirmation of the National Pay Award, but we are expecting it imminently. My assumption will be it's probably going to be higher than the 2% that we've got in or built into planning, but we don't know what level that's going to be, and obviously therefore we don't know how the residual funding issue is going to be dealt with if it is higher than the funding that we've already received as part of the original 22-23 settlement. So element of risk, but we won't be able to make any judgment on that until we get any guidance, which I'm expecting later in this month. So moving on in terms of performance to the end of month 2, I'd say we probably made a steady start to the financial year. We're not seeing any real significant variances to the plan that we originally submitted, and deficit to the end of month 2 is 900,000. Worth probably just flagging a couple of things. Workforce, I think we'd accepted that despite trying to temper ambitions around workforce recruitment, we are seeing slippage against our substantive workforce plan in terms of levels of recruitment we were expecting, and that is being offset at the moment by higher levels of temporary staffing spend compared to last year. We're continuing to review the temporary staffing position. From what it appears at the moment, we've not seen significant increases in rates or price cap breaches. It is genuinely driven by something like a 17% increase in demand, and we're just reviewing to see which services that's occurring in, and the reasons for that, but we expect it to be linked to higher levels of sickness, including COVID, and higher level of vacancies in the plan in the first part of this year. What we are seeing though is at the same time we're increasing our demand for temporary staffing, we're also seeing an increase in shifts being taken up, so the overall fill rate is comparable to last year as well, which indicates there's more willingness from staff to take up these additional shifts, which could be cost of living related, but let's say we're doing some further work into that. In terms of cost improvement, we obviously built in a relatively low level of savings in the first part of this year, and we're 100,000 ahead of where we expected to be. We're just doing a Q1 review of the savings programme just to make sure we're clear on the schemes going forward for the rest of this year in terms of forecasting any that we think are going to have fallen by the wayside, and any new schemes that have come online or have been identified by divisions and falling out with the work that we did with the senior leadership team a couple of months ago. In terms of liquidity, we've got no issues at the moment. In terms of capital, we're slightly behind plan, but probably the more important thing to note around capital is, although in the revised planning guidance additional inflationary funding was given to organisations for revenue inflation, nothing was adjusted for in terms of inflation on capital schemes, and we're starting to see some of the tenders coming back at a higher level than we would have expected even after the additional contingencies that we've built in. So we're going to manage this obviously through the capital review group, but it could be that we're going to have to take a view in terms of reprioritisation of some schemes and timing of some schemes so that we can manage expenditure within our capital allocation for this year. And obviously we'll keep board and FIP fully appraised of any alterations to the plan as and when they occur. So happy to leave it there, Martin, and take any questions.
Okay, thanks very much. I suppose you mentioned it, but the workforce thing is clearly an issue, isn't it? Whether we can really recruit the plan. But Naomi.
Yeah, that's exactly where I was headed, Martin. I mean, I'm referring, and everybody can see the same thing that I'm seeing. I'm referring to page 194 of the pack, and that are, you know, because this really strikes at the integrity of the plan, and in recognising that we are from where we are now to where we would like to be in the plan is a sort of net increase in workforce of nearly 400 people, and I just think this is an ongoing conversation, Martin. I know there's no easy fix, but I just think we as a board through FIP need to be super conscious of where this might be headed, given the constraints on workforce, the implications of how that might impact on non-permanent staffing levels, and how that might impact on people's willingness, etc., to take up the slack in terms of in terms of bank and agency staff. So I guess my message is clear. I think we just need to keep a really beady eye on this. I don't think if I said anything else, it's anything that nobody else is thinking at the same time.
No, but as always, Naomi, you've very eloquently said. So, I mean, I totally agree, and it's a worry, isn't it? Because if you're looking at the extra hours worked, I mean, there's a point at which that will start to level off, either for safety reasons or just because people aren't willing to do those extra hours. And I think we need to be very focused on how we can use the staff, or how we can retain them, of course, how we can use them most effectively, because some of the staff we can recruit are non-clinical. I assume they're doing things that would relieve tasks from the clinical staff. But I think it definitely needs, close scrutiny. But it's not a new problem, is it? It's one which isn't going to go away.
That's right, Martin. I think it's not a new problem, but the way we've crafted the plan, which we all support, means that the ambition in terms of workforce recruitment is high. Absolutely. And our ability to fulfil that in a sustainable way, we just need to acknowledge the difficulties that are inherent to the system right now, and are not going to change anytime soon. So I think increasingly we need to understand through the executive what are the sort of creative ways in which we're going to manage this through to the end of the financial year in a way that actually I think the broader solution lies in system working, and how we might develop that opportunity, in a really robust way.
Yeah, and I guess it'll be part of our discussions under the strategy refresh in the autumn, because it's not a short-term fix, is it? It's going to be a longer-term issue. But Tamina's got the answer, so let's hear from Tamina.
I have, yes. Unfortunately not. I'll save that for the next meeting. I had a really helpful session with my ops leadership team yesterday, and we were discussing this partly in relation to, I think, the cost improvement that we're required to deliver this year and next year, but also just more widely in terms of that feeling the burden that staff are experiencing at the moment. And I guess much of that they do acknowledge, I think, and it's a conversation I'll have with Paul and with Minnie and with Debbie, what we do this year to enable us to do things differently next year. I think there's some things we won't be able to achieve, but certainly that sense that, I think Minnie said this before, we've taken out the sort of cheapest staff and we've left the most expensive doing really kind of basic tasks. And should we be reviewing that and thinking differently about that? What do we think about our skill mix? Do we need to spend an hour on assessment? Could we do it in 45 minutes? Are we really sort of managing the offer to patients in the way that we could do? So maybe the answer isn't that we need more staff, as some staff are saying. Maybe it's just that we need to be working differently. So there's a real appetite, I think, within the teams to start looking at some of that. And I think maybe not this year, but certainly next year we can start to see some changes.
Very good, very positive. Thank you for that. I think that'd be welcome. Okay, is there anything else to Paul on the finance? Can we go on to performance? We got the right to, performance report 8.1, Paul.
Thank you. So as usual, just go through some of the key driver and breakthrough target. So falls still slightly above target at 31. We had a welcome reminder in QPEG this month that if you look nationally at falls data, despite us being above our own target, we are below national average for falls. Probably something we want to just keep that bear in mind, that we're setting quite a stringent target ourselves in terms of levels of falls. Still seeing all of our falls happening on wards with high levels of occupancy, and we're still obviously continuing to do significant work to try and reduce that. Keynote probably was a rapid improvement event at Prospect Park Hospital this month, which despite all the pressures they're seeing at Prospect Park, was really well attended with a good cross section of staff. I think they've come up with a number of countermeasures which they're going to put into place over the next couple of months to try and see what they can do around pulling the current numbers down. And we're continuing to review the technology side of things that we're using to help monitor patients and move into a single trust solution at some point, probably later in the autumn. At the moment we operate 2 systems, so level of streamlining later in the year. In terms of self-harm, again, still slightly ahead target this month, and work involved in reviewing the safety huddles and safety plans for patients who are at high level of risk or restraint is currently undergoing. Physical assaults, positive in terms of being below target this month, and they're looking at post-incident reviews in Bluebell and Sorrel, which historically have been areas where we've had the highest number of instances. Only other thing probably to reference there is staff turnover as well, which obviously last couple of months we've exceeded our 16% target, so we need to keep an eye on that, especially given reference to the conversation we've just had around workforce and workforce numbers over the remainder of the year. But happy to take any questions on the remainder of the report.
Just on that particular point, Paul,
yeah,
maybe not you directly who answers, but if you look at the whole chart going across that row on the staff turnover, it's a very steady increase, isn't it? It's not just a blip in 1 month. I mean, it's a steady trend. Do we know which staff is it? Is it all staff that are leaving? Is it low paid staff? Is it specialist staff? Do we have any feel? Perhaps not now, perhaps afterwards. It might be useful to get some feel for that.
I can answer that, Martin, if you want.
Please, Jane, thank you.
Yeah, I can. The highest turnover is generally with new starters, as you find in most organisations. So it's people joining within the first 12 to 18 months. And we have particular peaks at grade 5 as well. So people come do a year of preceptorship and then move on. But we've got the detail. If you want, I can come back with
well, it's just to make sure that we are tracking it, that we and I'm sure we are, Jane, but it's a sort of to enable you to tell us that we are.
Yeah, absolutely. And I have to say my own recruitment team aren't helping that figure either. We're up at 15% turnover in the recruitment team, which doesn't help, but we can talk about that as well another time.
Martin, can I just ask Jane
Please.
A question on that?
Please.
Jane, are you noticing an increase in retirements? Because there's been a lot of focus on that, hasn't there? That post-COVID, lots of people who are nearing retirement age have decided that that's it. Is that also contributing?
Yes, it is. And obviously the age demographic sometimes doesn't help, because we do have a lot of people in the older age group. What we have been very successful at doing, though, is getting people to do what we call retire and return.
Yeah. I was going to go on to ask you about that.
Yeah, of course. I forget that you've got the background. Sorry.
No.
Yeah, so we are quite good at getting retire and return. And one of the other things that we are piloting, we're going to be the pilot for Bob and Frimley, actually, for their reservist projects, which is about trying to get people to come back and guaranteed to do a minimum of 30 days with us per year. And
yes.
they can do that, say, vaccinating, or to come back and help when we've got peak periods.
Yes, that sounds good. Thank you.
Okay, anything else? Okay, thanks very much, Paul. If we could move on to the item 9, equalities, diversity and inclusion strategy update. Jane, are you going?
Martin.
Oh, sorry, Naomi.
I don't know if someone.
Thank you.
Yeah, sorry, Martin. It's actually a really quick one, I hope. I just wanted to inquire about the I Want Great Care compliance rate at 0.6 for April. We all know this system is in its infancy, and I just wondered if, well, two things. One, would we expect that relatively low rate at this point in April? And two, do we have any projections of when or how we might get to the 10% target?
So it's increasing month on month at the moment, Naomi, is what I would say. So for April, we're probably going to see at least 3 times the amount reported, say, for July that we saw in April. SMS has been switched on now, which was a very good source of people giving us feedback historically before we moved to I Want Great Care. So I think that is progress. And what I would say is some teams are embracing it better than others at the moment, and there's quite a lot of work going on to encourage those that aren't. So we've done the all-staff briefing, trust leaders and managers, where teams that are using it really well are showcasing how they're using it, more importantly, what they're using the information for, what it means to them, how helpful it is. And I would say it's an ongoing piece of work, but it is going in the right direction. So, in April, I think we got something like, say, 400 responses or whatever. We've had that in the first 8 days in July. So it's going in the right direction. It's slower than I would want it to be, and it's an ongoing piece of work.
Understood.
Thank you. Julian.
Yeah, just very quickly to follow up on that, it would be really helpful when you're doing your service visits or whatever, if you could ask about it. I think, as Debbie says, we've got some services now who are very patient focused, who are making it easy for people, and we've got others at the other end, really, where they have it, but it's really hard to know about its existence. And so just having that conversation sometimes can be quite helpful, because the services we provide are so different, and there are some different challenges. But I do think we've got a bit of a cultural thing to overcome as well, with some services perhaps not so attuned to the benefits, both for the staff and the patients of this. So if I could ask, when people do their visits, if they could inquire to see the data, how it is, how it's publicised, it would be really helpful. Thank you.
Thanks so much for that, Julian. We will do, I'm sure. Okay, anything else on the no? In which case, if I can get my computer to work. Just on, sorry, we're on the qualities and did we get onto that? Qualities and diversity? No. Jane, is it you I ask? I've got a question about this paper, and it's a very well-written paper, but I get the feeling there's a lot of sort of generic stuff in there, and I think we sort of feel, don't we, if we discussed it past, that generic solutions are sort of, we know about those and we've known about them and we've tried them for years. It's actually being something more focused, I think, was the sort of position we got to. Are you able just to paint that little picture about what it is we should be doing now, rather than what we've been doing diligently but without actually the success we'd like in the past few years?
Yeah, I think
and reading the paper, it gave me a rather generic feel, which
okay, no, that's I think that's probably a fair comment, Martin. One of the reasons that we have brought Amit in, I think people have aware we brought Amit in on a 9-month contract, is to really shake up and review what we have been doing. So Amit has got a background in ED&I leadership and management, and we want to get to a series of very, as you say, a bit more specific, clear interventions. If I'm honest, I think there's 2 things that are going on here with some of our figures. I think we're not making the progress that we want, but what has been very good is that people are prepared to speak up in this organisation. And so I think we should be pleased that people are coming forward and telling us when they think things aren't working very well. But there are a couple of areas that we still haven't managed to tackle properly. The one of those is the bullying and harassment piece. We still have far too much bullying and harassment going on in the organisation, which has a disproportionate effect on our staff, particularly from Black and minority ethnic backgrounds and those with disabilities. So the work that we are doing there is that we have, as you know, we started on the Just Culture piece, and we started to do some OD interventions. It wasn't making the impact that we wanted it to, and with Amit's help, we reviewed what we thought were the gaps in the process and identified that actually what we don't have is any sort of formal conflict resolution process. So what we do is that we ask people to take some mediation, and that will often help in an early intervention case where we haven't got things escalating into a difficult situation. But we don't have a formal process with external facilitators to provide that independence and to formally try and resolve or surface conflicts and resolve those conflicts. So that is one area that we want to clearly want to focus on. And if I'm really honest, I think the other thing is that we have suffered here a little bit from pausing some of the leadership and management development training that during COVID. I think we did that because we had to prioritise other things. But what we are beginning to see now, particularly, is issues that are arising from what I would call inexperienced or weaker leadership that's being displayed. So these aren't people who are intending to create problems or intending to discriminate in any shape or form, but these things are happening because people aren't aware of what we would call good leadership practice and inclusive leadership practice. So we've done a lot of really good work on compassionate leadership. We have now continued to run the EMP program, but I think it needs a refresh, and we've started some work on that refresh now to really have a look at that. The third thing is that we're not making the progress, as you know, with regard to, sorry, this sounds really negative when actually there's some really good things in there as well, but let me talk about the negatives first. We're not making the progress in terms of, particularly for our BAME staff, progression into more senior roles. And again, the targeted intervention that we're looking at there is to develop not a talent program, but a sponsorship program for our BAME staff. So that is a different intervention. It isn't putting people on some sort of program that says you are, you're identified as having talent and will promote you to these roles. The talented people in the organisation will get there anyway. This is about what we call active sponsorship. So it's based on a program that's been running in the southeast, and that is where we get senior leaders to actively sponsor key individuals have been identified as having some talent but aren't actually being able to make it to the next level, and that would involve a slightly different approach to supporting those individuals. It's not coaching, it's not mentoring, it's about making sure that we that they are given the opportunities that they need to be able to apply for roles, that they're seeing roles, they're being introduced to the right people for opportunities, and they're being encouraged and supported to develop on their career journey. So those are the three main things that we are focused on from a people perspective. Obviously, from a patient perspective, we've been supporting the work that Mary has been doing on the neurodiversity strategy, and we will be picking up some of the lines of work in that coming out of that strategy, particularly around some of the training, but also some specific interventions. So, for example, we are running a trial at the moment where we are giving candidates their interview questions in advance. We're doing that with, we're going where the energy is. We're asking anybody who is interviewing at the moment whether they'd be prepared to be part of the trial. Some are eager to be part of it. So we've had Marcoms who've given us enormous amounts of support and saying that they will do that. Some areas are a little bit less convinced that they want to do this as yet. So at the moment we're going where the energy is, but that is about giving everybody interview questions in advance. The idea is that helps people who might have who might actually shine if they were able to see the questions and prepare the answers. That works particularly for certain people. For example, if you've got processing disorder, or for example, some people who have ADHD or are on the autistic spectrum may benefit from that. And it's a trial. We shall see if it has if it makes a difference and if it works. But it is a trial, and we're offering the interview questions to everybody so that anybody who is neurodivergent doesn't have to ask for that as a reasonable adjustment. So that's about reaching out into the population and trying to recruit people from different backgrounds and different and allowing people with neurodiversity to perhaps enter the organisation and have the opportunity to progress in the organisation.
Thank you, Alex.
Thanks, Martin. And it goes to Julian's earlier point about taking, understanding where the issues are across our services and taking action there. And in Jane's paper, we do reference a very specific hot area around racial abuse at Prospect Park and the impact daily that has gone on for too long with staff experiencing abuse from patients. And from the Rapid Improvement event last summer, some very focused action has been taken that staff recognise and acknowledge is making a difference in terms of us now changing the culture there and not accepting abuse, acting upon it. Patients are also seeing that we're acting upon it, and it is helping them to reflect on their behaviours. So we're creating a good virtuous cycle there. But my point is we need to communicate the work we're doing in that place, understand where we need to take that kind of action in other places and continue to take action rather than talking about it. I think we shared what we're doing with our Surrey and Borders colleagues, and they have very similar issues around racial abuse in their mental health inpatient units, and were really interested and pleased to hear we felt able to take action, understanding clinical risks, and I'm talking around discharging patients where appropriate and safe to do so for behaviour concerns. And we have taken that kind of action, and I think regionally we're one of the first or the few to do it. So people are watching how this works. It's creating a ripple for staff. They're seeing we're taking action, and my point here is focused action we need to take on. The leadership and management development, there's a bit of a risk around silo approaches to EDI interventions. So I think creating a programme that has inclusion at its core to support our leaders and managers is a good approach. It's not generic, it's the future kind of fit for purpose leadership and management development that we need. And so I'm really pleased to see that Jane and Amit are taking that development approach and giving it some thought and bringing that back onto the cards post-COVID. Thank
you, Alex. I mean, it does seem to me, and I'm pleased to sort of hear it, that, and I know it's there because we've discussed it before, but I've written down focus on my pad here next to the computer. It's actually identifying interventions where we can actually make something happen, like the Rapid Improvement event at Prospect Park, which I'm very pleased to hear about. And I think we just need to sort of keep focusing on those things as we understand the problems, rather than too much generic stuff, which I suspect is not going to change the dial much. And in terms of leadership management skills, I just always reflect on whether we select our managers as carefully as we could when we're selecting them, as opposed to trying to train them into good managers when they've already got into post. Because some people don't have, it's not a criticism, it's just that they're not the sort of people for whom management is their natural forte, and trying to turn them into something that they're not is not going to help anyone, less alone themselves. So I just sort of feel there's a bit of thought about how we choose people for management as well as how we develop them. That would just be a reflection. Tamina.
Yes, certainly conversations I've had sort of helpfully with Jane and with Amit are what support we put in place when people do move into their first managerial role. I think you often find people move from being a peer to being a line manager, and that can be tricky. And we have our most inexperienced managers managing our most diverse workforce who are kind of directly interfacing with our patient services as well. So the different things that we might be able to put in place. So it might be some combination of that sort of sponsorship, that mentoring, that coaching as well. So they have the opportunity to reflect on some of that and how we build that into. If people see managers behaving like that, then when they move into a managerial position, they're more likely to see that as the way in which we expect our managers to behave at BHFT.
Thank you, Tamina. Any other questions for Jane? Alex? Okay, thanks so much indeed. Thank you, Alex. Thank you, Jane, for all you're doing. Audit committee. Thank you. Audit committee. Well, Reggie's not here today, but it looks a fairly straightforward. Has Naomi or Mahmuda got anything you wanted to add, or just don't feel you have to? But if you, oh, Naomi has. Go on.
Yeah, less about the content of the last audit committee and more a bit of an update, actually.
Right.
If you wouldn't mind, Paul, on the approval of the accounts, given that we've got this ongoing issue between Ernst & Young and the property valuers.
Okay, so currently we've not obviously got signed off accounts for last financial year, and this Friday will be 3 weeks post the original submission date set by NHSE. We've got two factors happening at the moment. One is we've got a small number of transactions which the auditors have flagged, which we need to take a view on whether we're going to adjust or not. But that's that's a minor issue. The issue that's holding up the delay on the audit is a issue between the district valuer and Ernst & Young, and put very simply, the district valuer has come up with a valuation predominantly for our two main PFI sites, West Berks and Prospect Park, which is coming out at a particular cost per square metre. And Ernst & Young have compared this to national building indices, which gives a approximate range for what they would expect hospital facilities to be valued at, and the DV's valuation is coming out at the lower end or below the lower end of what that range is, and Ernst & Young are challenging the DV on justification for why that would be, and we're in a protracted conversation between the district valuer and Ernst & Young to get the required level of information to give Ernst & Young the assurances they need that the valuations are appropriate. So I had to write to NHS England last week to inform them and give them an update on where we're currently at and how long we think this is going to take to resolve. Had assurances from DV last night that they're engaging their building surveyors and cost engineers to provide the information that's required. I have to say, we've not come across this situation before. DV have said this is the most stringent challenge they've had to evaluation in their experience as well, and that's obviously part of the reason why NHS England are interested in this, because again they want to understand why this is of such a significant issue. So we are taking steps to resolve it. It's taking longer than we expected. As a backup, we have engaged a second valuer to take a look at the valuation as a precaution in case we can't get EY and the district valuer on the same page in terms of the valuation. It's not something we want to do. It's not something that NHS England would encourage us to do, but given the option of that or qualified accounts, we don't really see that we've got an option at this stage but to have that backup plan in terms of contingency.
Thank you, Paul, and supportive of the interventions that you're taking, in particular the escalation to NHS England.
Okay, thank you very much. Anything else on audit? Okay, Councillor Governor's update. I've been doing the inductions for the new governors. The governors' meetings, the governors are all very engaged and very positive in their role. One thing that I'm talking to governors about, or will be soon, is about the future of the Living Life to the Full committee of the governors, following the retirement of John Barrett, who was the long-serving chair. And in discussion with the lead governor, the sort of feeling that maybe we can evolve that to take a broader view of all the services outside our own services that support patients, and therefore for more of a systems view. So we're going to have a discussion at either next governors or whenever it is, I can't remember when it's scheduled, so we can have a broad discussion about helping the governors get a view of how these other services outside the NHS are all joined up and how they work. So that is that. Happy to take any questions if anyone's got any. Okay, any other business? Date of the next meeting is, public meeting is the 13th of September, unless there's some problem. And we'll now consider a resolution to exclude the press and public from the remainder of the meeting.